And we start with inviting the co-chair, Dr. Ashal Pal, to please have the seat. Our first presentation is by Professor Tayyeba Gul Malik, Through the Lens of Hope, Success and Setbacks in Retinoblastoma Care. Ma'am, please could you start the presentation?
The outcome was tumor regressed, vision was improved, and the lesson we learnt was timely referral and protocol-based care will lead to excellent survival and visual prognosis. This is the patient, bilateral retinoblastoma, group B tumor, and this is how it has regressed after IVC and added focal photocoagulation. Case 2, delayed presentation with limited options. 2.5-year-old child presented with unilateral leukocoria. We discussed with the oncologist and they said that the eye should be enucleated, but we decided to give a trial of intravenous chemotherapy along with the intraarterial chemotherapy. And the end result was, this is the unilateral retinoblastoma, and here the tumor has regressed. 6 cycles of intravenous chemotherapy along with 2 cycles of intraarterial chemotherapy. The child is so far doing well. Case 3, Group E. This is the pre-treatment. 8 cycles of intravenous chemotherapy were given. We gave intraarterial chance of intraarterial chemotherapy, but the eye could not be saved. And this is the post-treatment. At the end, we had to enucleate the patient. Case 4. A very heart-touching story. A child came to us with unilateral retinoblastoma. Enucleation was done along with the intravenous chemotherapy. The patient thought that the parents thought that the child is cured. They went back and didn't come. They went away and didn't come back. After a year, the child came with this picture. Regrowth of retinoblastoma. And the tumor had spread to the brain. After some time, the child died. Case 5, genetic challenges. We had a patient whose family was suffering from retinoblastoma. Father had one eye enucleated. The son had developed bilateral retinoblastoma and died. And the sister was screened. Then they thought that the screening must be done. So the sister was screened and early retinoblastoma was, group A was detected on routine screening and the child was saved. So the successes of our department are earlier. If the recognition is early, the treatment is good. We have improved imaging and risk stratification along with the consultation with oncology people from Children's Hospital. There is availability of intraarterial and intravenous as well as intravitreal chemotherapy. We are growing multidisciplinary teams along with the pediatric department of Lahore General Hospital as well as the Children's Hospital, oncology department of Children's Hospital. And the follow-up, and there is stress on improving the follow-up adherence, as the case 4 showed that the patient lost to follow-up. We also come across patients when you tell them that their eye has to be enucleated, they go to the Peer Fakirs. And then when they come back, the disease is at the last stage. Our setbacks are because of delayed presentation, high treatment abandonment due to the cost or distance, uneven access to specialized centers, especially the areas where the Peer Fakirs are present and the rural areas, lack of genetic testing in families, and post-enucleation rehabilitation gaps. Sir, आप लोग तो rehabilitation कैसे कर रहे हैं? पेशेंट जो इन्यूक्लिएशन वगैरह के आते हैं, आप लोग तो खुद करते होंगे ना? Now the lessons learned are early detection is life-saving and vision-saving. We have to strengthen the referral system. मैं बल्कि आपसे बात करना चाह रही थी कि हम आपके पास रेफ़र कर दिया करें फॉर रिहेबिलिटेशन. इस वक्त हमारा जो प्रॉब्लम मेन आ रहा है, एक तो लेट डायग्नोसिस है ही है, लेकिन जो रिहेबिलिटेशन है टू अवॉइड द डिसफिगरमेंट, उसके लिए मैं आपसे इंशाल्लाह डिस्कशन करूँगी. Reduce dropouts to improve compliance and national registries are very, very important. Sir, आप लोग lead लें और national registry करें. So that we should know what is the prevalence and what is the incidence of this disease, which can, with the survival rate of 95% in the developed countries. हम क्यों नहीं कर सकते? Future goals are expansion of screening centers, national genetic screening programs, tele-oncology. मेरा ख्याल है tele-oncology पर भी आप लोग काम कर रहे हैं. And psychosocial support and prosthetic rehabilitation. Retinoblastoma care is a story of remarkable success, but persistent gaps continue to affect children in low resource settings. Through collaboration, awareness, and equitable access, every child deserves the same lens of hope. And when we detect early, treat decisively, and support families, hope becomes reality. And thank you very much.
On bridging the gap, the role of genetic counseling in hereditary retinoblastoma in resource-limited setting. Dr. Arooj, please.
I'm Dr. Arooj Amjad. I'm working as assistant professor in the Department of Ophthalmology, Lahore General Hospital. And as you can see the topic, so retinoblastoma, what we already know, and it's been emphasized again and again. And this is a picture of a patient of mine. What do we know? 40% of the cases are hereditary due to germline RB1 mutation and autosomal dominant 50% inheritance risk. This is what we already know. And the genetics, a refresher of the genetics of the retinoblastoma, the genetic basis, the transmission pattern, the penetrance, and laterality risks to siblings. Now, what was the problem? There were families coming to the retinoblastoma clinic and they were having multiple affected children. There is no structured referral pathway for counseling or testing. Genetic testing is also not available everywhere, and there is a need for genetic counseling. Now, what happened was that I have a case series of 6 hereditary retinoblastoma families. The pedigrees, the history, the laterality, the age of diagnosis, documentation of access barriers, and everything was documented and everything was formulated. And what did I find? Why were they not counseled? Or were they counseled? When a patient comes to us, we all are doing whatever we can to treat the retinoblastoma. How is it possible that we have not counseled our patients? So this is what I collected, the data. And the 6 families, the genetic counseling to an extent was done by the treating physician or the treating surgeon. We all counsel our patients to avoid future pregnancies so as not to pass on the disease to the future children. But still, we are, as you can see, 4 children, 3 children, 2 children, all right. And then 2 genetic counseling was not done in family number 4. And family number 5, genetic counseling was done still. She's expecting again. And family number 6, 2 out of 2 children. And you can see the outcomes also in all of these. So, why? Even if we have counseled the patient, why do we have this burden? When the patient comes to us, they present with the 4th child being affected, the 3rd child being affected, and they have a history of losing 2 children to the retinoblastoma and losing the eyes of the children, enucleated, and rehabilitation it's an emotional burden, it's a financial burden, it's a huge burden on the society and on the family themselves. But still, they go on producing more children. So I came across this decisional conflict scale for genetic reproduction. It is a 16-item assessing the uncertainty, clarity, support, and decision confidence. And it helps to show the mass conflict in the families lacking the genetic counseling. So it reveals the emotional and reproductive burden hidden behind the clinical presentation. So this was the scale, and it has 5 constructs, and in the 5 constructs there are 16 items. You can read the items. This is the scale. So it measures the uncertainty clarity, and it's a 5-point Likert scale scoring system, and the higher the score means more decisional conflict. So this is the interpretation of that scale, the scoring system. High conflict, 37.5. The value of more than 37.5 shows high conflict in the decision making. So these were the results of those families. We asked the questions and they gave the answers, and we did the scoring according to the Likert scale. And this is the score of first 3 families, and this is the score of the next 3 families. As you all can see, this is a summary of the result. As you all can see, they all are scoring above 50. It means it's a very high conflict rate. Whether or not to go on with planning the family or producing more children, they all are conflicted in that. And why it matters? Because the families experience high hidden conflict, lack of counseling leads to uninformed reproductive decisions. And this scale, this tool which I have used, it highlights the unmet psychological and informational needs. So the O's and the Y's: the low awareness, social and cultural pressure of having a baby boy, social stigma of the hereditary disease, and the cultural stigma of planning a family. These all are the causes that lead to these decisional conflicts. And parents keep on passing the hereditary retinoblastoma to the future generations. And out of the 6 families that I have mentioned, I think 3 out of 6, father was the prodome. So what to do? Genetic testing. Of course, genetic testing is not readily available in our resources, in our setup, but we can do the proper structured genetic counseling. And the counseling should be structured in such a proper way. It should address every single question, every single concern of the parents who are going to make the decision in future. And how do we do it? What I suggest is we should hire a genetic counselor, a personnel who has the knowledge of everything and who is dedicated for this work alone. Of course, being the treating physicians, the treating surgeons, we do it all by ourselves. But maybe we cannot stress upon it that much, or we cannot readily explain it to them that how important it is not to pass on the disease to the future generation. So a genetic counselor who is dedicated for this work alone should be the answer. These are some references, and thank you very much. If you have any questions or comments, please. Thank you very much.
Assalamu alaikum everybody. I am Fatma Zara. I'm working as Dean's Clinical Research Fellow at the Department of Ophthalmology at Aga Khan University. And I will be presenting on behalf of Dr. Khadija today. Our topic is Impact of Health Belief Model-Based Education on ROP Screening Knowledge and Practices Amongst the Parents. So this is an educational interventional trial that I will be talking about. And what we will be discussing is how educating the parents can make an impact on ROP screening. The burden of ROP. So talking about the global impact, ROP affects 184,700 premature infants annually, 20,000 become blind, and 12,300 suffer severe impairment. In terms of Pakistan, incident rates range from 16 to 26.8%, driven by high preterm births and suboptimal neonatal care. The severity depends on oxygen duration. Damage may present as retinal detachment or macular folds. Now, when we talk about bridging the knowledge gap, the challenges we have are, number 1, lack of awareness amongst the parents. Number 2, the barriers. So the parents often misunderstand the critical window for ROP screening. और आप लोगों ने देखा होगा clinic में, like we as students observed, parents with their babies of a year or 2-year-old would come to us and they'd be like, Dr. Saab, ये बच्चा देख नहीं रहा, मतलब हमारी तरफ नहीं देखता. And once you screen them, you realize that they had ROP, and now unfortunately they won't be able to see, just because those parents, nobody told them about ROP screening, they never went for it. And then when we talk about barriers, it is access to healthcare, anxiety, and language differences. So, what's the solution for this problem? What we developed is a health belief model. We believe that empowering parents by addressing their perceived susceptibility and severity of the condition, educational interventions such as video and audios can significantly improve preparedness and satisfaction of the parents. So, our study objective is to evaluate the impact of educational interventions based on the health belief model in improving ROB screening and practices compared to control group in a tertiary NICU setting. Our hypothesis is that there is significant difference in ROB screening knowledge and practices among parents who receive health belief model based educational intervention compared to the control group. Our design, and this is the study that we will be starting at AKU. We just got the NBC approval. Our design is a single blinded randomized controlled trial. It is single blinded because we will be assigning the educational intervention to the parents, but they will not know which group they will be in, whether it's video, audio, or pamphlet. Setting is NICU set up at Aga Khan University Hospital in Karachi, and participants would be parents above 18 with premature infants, either less than 37 weeks of gestation or less than 1500 grams. Our total sample size is 132, so it's I'll explain it to you. It's a 4-arm study. Each group will have almost 30 parents. So participants will be randomly allocated into the 4 groups. All groups will receive user-friendly pamphlets. So we have ROP educational pamphlets in our clinics available all the time. So these will be given to all the parents. In addition, so in arm one, we will have a video message that has been recorded by an ophthalmologist. It's in both the languages, English and Urdu, and it's talking about ROP, what time they have to bring the baby to the clinic, how important it is. Then the other one is the audio message. So it is the audio of the same video that we will be showing, but it's just the audio. The third one will be patients will be counseled regarding ROP one-on-one by the doctor. And then the fourth one, which is our control group, is just the standard pamphlets that the parents are already getting. So this is how our study will follow. Firstly, enrollment, so screening, NICU records, and informed consent. So any baby that comes to ROP, they will undergo ROP. Any baby that comes to NICU, it will undergo ROP screening, and then informed consent will be taken from the parents. We'll then give parents a pre-test that's regarding the health literacy questionnaire. So that has questions regarding ROP, just to check their knowledge, how much do they know. Then allocation will then be putting them into the arm. So either they'll get a video or an audio or a counseling group where they will be counseled. And then finally, once the baby will be discharged from NICU, we'll then take the post test, which is going to be the same, and then we'll assess which group has scored the highest. So this is how we plan to do the analysis. It's very biostat heavy slide, so I'm not going to go into detail, but I'll tell you what it means. We'll just be comparing the results of all the groups, the mean score in all the groups, and we'll see which group scored highest. So let's say if the group that was given the video intervention that scored highest, then we're going to implement that within our clinic and within NICU settings. Okay. From now onwards, we will be showing this video to all the patients, to all the parents of babies at NICU. So what are we expecting? The findings will provide invaluable insights into effective parental educational strategies, potentially serving as a model for neonatal healthcare practices globally. So our goal is to improve clinical outcomes and reduce ROP-related blinding. Thank you so much. If someone has any questions, we have Ms. Khatija to answer. Yes, sure.
So 37 weeks and 1500 grams. किस basis पे आप लोगों ने ये guide?
This is the international guidelines that's being followed. Different, yeah. Yes. Yes. Yeah.
I don't think I need to repeat that. So
Yeah, we heard you.
Yeah. And Prepara के guidelines के मुताबिक हम लोग 2 kgs or less करते हैं in
Right.
Pakistan.
Right.
So I feel like 1500 पे you will be missing out on a lot of babies.
So, sorry, you were saying
You
what
guys-
are you following in Pakistan?
Propera guidelines.
right?
So उसके accordingly it's 35 weeks or less, 2 kgs or less. Even हम लोग जो हैं, go on.
So 1500 is less than
You
2
will
kg.
miss out on a lot of babies.
You're absolutely right. I think most of the confusion will be over tomorrow. Tomorrow at 10:30 there is a session and
Yeah.
new guidelines have been finalized
Right.
for retinoblastoma, for myopia correction and so many other things, glaucoma and ROP.
Right.
So tomorrow's guidelines will show 2 kilograms,
Okay.
okay,
Right.
and 36 weeks.
Okay.
Okay. Propera also, I think, finalized on 36 weeks.
Oh, okay.
Okay.
Yeah. So 36 weeks and 2. Although I've seen at least 7-8 babies with 2.2, 2.3 kg
Yeah.
as well,
Right.
having ROP, and as higher as 38 weeks having ROP.
ROP.
But then that will open hundreds of thousands of babies, you know,
Right.
and you can't cover all that. There are exceptions, and so that's why in those guidelines, 36 weeks, 2 kg, oxygen delivery, and if some baby has had a slightly unusual course, you know, in the neonatal time at the NICU, baby was sick, having infections, was given more oxygen, then they will be included on the discretion of the neonatologist.
Right.
So yes, that
And
will be
just
finalized
following
tomorrow.
up on what you said, so you're saying 2 kgs, which is 2000 grams. We're saying 1500 grams.
You-
So that's lesser than 2 kgs. So we're not going to miss out on people. We're going to have even
Yes.
babies with
No,
smaller, with lesser weight.
You are going to miss out.
So isn't it?
Yeah, it's the other way around. You are 1600 grams you will not see.
Yeah.
That should have been seen.
1700 grams you don't see.
So our criteria, I'm sorry, maybe I didn't make myself clear. So our criteria is babies with less.
It was written
okay,
1500.
okay, I got it. Okay.
So the thing is, internationally, yes,
Okay.
they have brought it down to 1500.
Okay.
But because their oxygen protocol is perfect,
All right.
okay, and I agree, your oxygen protocol at Aga Khan is also nearly perfect.
Right.
So maybe they won't have problems.
Right.
But if you go by the guidelines which will work in Pakistan,
Right.
then it should be under 2.
Okay. Okay.
Okay?
Right.
Wanted to add one thing. In this study, we are not doing ROP screening. We are just looking at the impact of educational intervention before and after. Like we are going to counsel the parents कि आप NICU में आपका बच्चा है, इसको ROP screening के लिस्ट पे है, इसको जाना चाहिए. तो जो हमने educational intervention दी है, उससे उसके ऊपर कोई impact आता है या नहीं. So ROP screening is not our outcome. We are just going to measure their knowledge, increase in knowledge before and after.
तो उसके अंदर तो
बस आपने
Yeah.
We are just going to revise it according
But-
to the new guidelines.
Yeah.
But the main outcome variable is knowledge of the practice.
वो तो ठीक है, वो तो ठीक है. लेकिन आपने एजुकेशन आपका तो गोल तो एजुकेशन है.
Yeah.
So education के लिए you're missing them out.
Right. Right.
So, I am saying that we are going to revise according to the new guidelines, which you are saying.
Yes.
But the outcome is not like we are not
The
going to
management
measure कि
plan is
कितना
not going to be
ROP
disturbed.
कितना इंक्रीज हो गया उसका स्क्रीनिंग रेट. हम इस स्टडी में वो नहीं चेक करेंगे, सिर्फ नॉलेज को असेस करेंगे बिफोर एंड आफ्टर.
ओके. एक और चीज़ थी. आपने कहा था कि आप लोगों की वीडियोस और ऑडियोज जो है इंग्लिश और उर्दू में होगी.
Yes.
आप लोगों की रीजनल लैंग्वेज क्या है?
Sindhi.
सिंधी.
Yeah.
तो जो पेरेंट्स हैं जो सिंधी
Yes.
बोलते हैं, डोंट यू थिंक रीजनल लैंग्वेज में भी आपको ये करना चाहिए?
We should definitely incorporate it, and I personally feel we should have it in other languages just to keep it simpler. And to be very honest, we did not have.
At our main Khan center, which is in the main city of Karachi,
Yeah.
most of the people coming in are Urdu speaking.
Okay.
So we are not targeting the areas which are like, अगर we are doing this study in Jinnah Hospital, तो वहाँ पे major chunk हमारा interior का आता है, they speak in Sindhi.
Okay.
But at Aga Khan they either speak in, because हमारा lower income group वहाँ पे नहीं आ रहा होता, high income group आ रहा होता है.
Okay.
तो either they speak in Urdu or in English language.
Okay. Okay. Makes sense.
अच्छा,
Those are very valid suggestions. Thank you so much.
ये जरा ये ग्रुप्स की जरा आप
Yeah.
दोबारा दिखाइएगा.
Oh.
अच्छा, I was wondering कि video message was the most powerful medium.
So we have to do the study. Abhi humne start.
done a
अच्छा.
pilot testing or
We have not done it yet. Pilot we haven't.
लेकिन लिटरेचर हमें वीडियो का ही है.
Otherwise, counseling, one-to-one counseling, I think it has the most strong impact.
Yeah. So that's
How
what
can
we're gonna-
video, can be more powerful?
Want to check कि कौन सा सबसे अच्छा है.
बताएंगे हमें next test.
सर मैं एक्चुअली आरओपी क्लिनिक रन करती हूँ पेशावर में. तो ऑब्वियसली अभी स्टार्टअप है मेरा. उसके अंदर हम लोग क्या करते हैं कि वीडियो मैसेजेस जो है ना हम लोग पहले से ही ओके दिस इज गोना साउंड फनी बट वी एक्चुअली हैव अ टिकटॉक अकाउंट. तो उसके ऊपर हम लोगों ने वो क्वेश्चन सारे एड्रेस किए होते हैं पेरेंट्स के जो कि वो नॉर्मली पूछते हैं और हम लोग उनको सेंड करते हैं वो अकाउंट. दे वॉच द वीडियोस एंड देन व्हेन वी हैव द फर्स्ट सेशन जो हमारा फर्स्ट
One-on-one.
कॉन्टैक्ट होता है जिसमें हम लोग फर्स्ट स्क्रीनिंग करते हैं तो फिर 1-to-1 काउंसलिंग करते हैं. तो इट्स ईजियर. सो वीडियो प्लस काउंसलिंग.
Yeah,
Thank
maybe
you
we
very
could have a video plus counseling group, maybe with the advanced setting. But thank you so much.
Thank you so much. Now I'd like to invite Dr. Syed Asad Ali for his presentation, Retinopathy of Prematurity, Laser versus Anti-VEGF.
I'm Dr. Syed Asad Ali. I worked at Moorfield Eye Hospital in Abu Dhabi. Thank you very much for organizing committee to invite me to present retinopathy of prematurity, laser versus anti-VEGF. No financial disclosure. The hospital had to screen ROP. It's Abu Dhabi and Al Ain. So I'll be discussing few typical cases, some clinical studies, and method and equipment, and then comparing the two types of treatments. So the history of ROP treatment has evolved significantly since its first notice in 1940. Now, initially just to identify it and then later developing into sophisticated surgical treatments and intervention. Now we are living in a third epidemic of ROP, and the neonatal care is getting better, but the screening is not enough. So case one is a baby girl with 580 grams, 25 weeks, 5 days at birth. Corrected age 38 weeks, notice stage 3 in the right eye, zone 2, and right eye stage 2. So that's, and fundus fluorescein angiography is showing some leakage at the vascular junction. So the plan is to do a laser treatment. Yeah. So this is post laser treatment. Sometimes I give, like in the lower picture, you see a row of laser scar marks in vascular retina, and especially if it's a slightly raised retina or not getting a posterior to the ridge, not getting a reflex, then I give a single row on the vascular retina. So treatment started originally in 1960s, were like radiation and some surgery, which was not effective. Oxygen, although it causes ROP, but has been used for treatment in vasoproliferative stage. I'll not say that it will prevent laser injection, but it may delay it. Because at that stage, if you give more oxygen or keep a high saturation at 97, 99%, it can delay the development of plus disease or aggressive ROP. Cryo was in 1980s was the first treatment which was effective in ROP treatment and saving from detachment and blindness. So, and then in 1980s, this laser started. So current standard treatment is either intravitreal injection of anti-VEGF, laser treatment, or in advanced cases of stage 4 and 5 is surgical interventions. So laser started with xenon, then krypton laser, but then at the moment the best we do it with diode laser, less risk of developing cataracts. Argon or this green laser can be used as well. So this is Neolase. It's a wireless laser technology, so less risk of like fiber optic damage or anything. It's a voice control system, and on the right, it's even can be done sometime if the baby is not fit for anesthesia, it's under topical anesthesia or sedation. So BTROP trial was the first landmark trial, multicentric, for use of anti-VEGF. So Westin was used in 150 babies, 300 eyes, and it has shown us superiority over laser treatment in zone 1 disease. So lower recurrence rate, especially in zone 1 disease. But zone 2 has no significant difference between laser or injection. So, and different medication can be used. Like now in UAE, Lucentis is or ranibizumab is licensed treatment. So we're not allowed to use any other medication. But worldwide, Avastin is the most used for ROP. I have before it got licensed the ranibizumab. I used aflibercept as well, and in my experience, there were very few. I've not seen any reactivation. But with Lucentis, I see about 40 to 50% reactivation or avascular peripheral retina. So good, very aseptic technique. Iodine is used, and we use it like 1.5 millimeter from limbus, using 30 gauge needle, using like 0.2 milligram of ranibizumab intravitreally. So main complication include endophthalmitis, raised intraocular pressure, cataract, especially if it's a direction of injection, or damage to the lens can cause cataract, retinal detachment, corneal abrasion, uveitis, acute vision loss because of central retinal artery occlusion, subretinal hemorrhage. That's the main side effects, but they are not common. Like most maybe it's uneventful and get very quick recovery. So systemic side effect or potential side effects. So all studies, none has proven the systemic side effects. But like neurodevelopment, this rainbow study is still ongoing for a later stage result, so for at 5-year post-injection. But it's not confirmed any neurodevelopmental disability. There are case reports, but not any study proven it. Same true for lungs, same for cardiovascular system. Like adults have a higher risk of myocardial infection or strokes, but not in pediatric neonates. So rainbow study had 3 arms with low dose ranibizumab, very low dose, and laser it compared. So it has 3 arms in this group. I'll just skip this one. But in general, this study from Turkey has a similar, we are seeing in our group about 48% reactivation. With ranibizumab and aflibercept has only like 13% reactivation. And and we normally follow for about 12 weeks, but if you're using aflibercept, it needs a much longer follow-up. So 12 weeks we do weekly checks. So case 2, a baby boy, weight 470 grams, gestational age 23 weeks plus 1 day. There were comorbidities with hydrocephalus, septicemia, and anemia. At 32 weeks, corrected age, and second screening, noticed like stage 3, zone 1 with plus disease. So Lucentis was given. So yeah. So this is 3 days post Lucentis. It's already like plus disease is cleared, as if you compare like on this one, the blood vessels, the branching at the margin, like avascular zone is already resolved. Few hemorrhages are resolving. So it works very quickly. So now I'll compare the two treatments on the basis of mechanism of action, indication, efficacy, advantages and disadvantages. So both have very different mechanism of action. Like laser is photocoagulation. You ablate the avascular peripheral retina and reduce VEGF production. It's a permanent destruction of peripheral retina. So it's the recurrence rate is low. And anti-VEGF neutralizes the VEGF, and it's very quickly acting and stop the neovascularization. So okay, I'll go. Yeah. So advantages and disadvantages, but on quick comparison, it's Intermittent injection is easy to learn, very quick, no need for general anesthesia, rapid response, but you need to know, depending upon the pharmacological agent, has a high recurrence rate or reactivation. And when you're treating later on, need fluorescein angiography. Indirect laser is a big, long learning curve, takes time, usually need general anesthesia, and recovery is slow. And there's a risk of myopia and consecutive visual field. But in my practice, even after 8-9 years, and now they do visual field. Normally, you're 25 or 30 -2, it's usually the full fields. So in conclusion, both treatments are very effective, and main important thing is to selecting the right treatment at the right time. Thank you.
Couple of comments.
Yeah.
Thank you very much for decades experience as well as an ROP. So what I've seen is that I've rarely had to use aflibercept, because sometimes when there was shortage of ranibizumab, only then we used it. And this was one disease where we could tell that, when they claimed that aflibercept has longer acting than the other ones. The recurrence rate in ranibizumab is more because the effect lasts about 5, maximum 6 weeks, 5 weeks usually. And this is the only disease where we actually saw that at least for 2 months, aflibercept will not let anything happen. But we also noted, because I did a lot of observation on that it also slowed down the normal vasculature. So aflibercept controlled the ROP, but also slowed down the normal vasculature. So at the end of 2 months, so that was good for babies who cannot have GA or laser treatment due to any reason, and that you're going to need 2 months or something like that, then aflibercept was very useful. The other factor is that in circulation, ranibizumab, in general circulation, it's gone after 24 hours. But bevacizumab is found after 27 days, and aflibercept is also found in the stream after about 20 days. So that makes it more safer, the ranibizumab group. So that was one thing. The other thing is, I always used to divide. For the last 25 years, I have made 3 divisions of zone 2. Because early zone 2 or posterior zone 2 is far away from the outer zone 2. And that is only then you can know, in the next 2 visits, whether it has progressed or not. So finally, the American Academy has put down posterior zone 2. They have added it. Hopefully they'll divide further into 2 as well. So I usually keep outer zone 2 for laser. If the disease is after outer zone 2, or if it's inside, because that's cure. We also have to see, patients getting tired, their parents getting tired, the grandparents not letting them come for treatment or something. That's a cure. And but with the injection, you always have to follow up. And when they say, there is recurrence after the injection, obviously there will be recurrence because effect will pass off. So I think dividing zone 2 is also very important for future, and then deciding your treatment. But yeah, I think you're the first person who has shown that you apply laser. The Americans were not happy with this laser posterior to the, and I think that's a wonderful idea, because a lot of times I also do that, a couple of rows, and on that on as well, on the ridge as well. It always helps, because there's no dragging in those. Other babies will have some dragging sometimes.
So I only do it in case of ridge is very raised, or any anteriorly to ridge I'm not getting any reaction, then always go 1 row or 2 row on the vascular retina. I agree with all your comments, and one is my protocol is also in case of after suppose there is a peripheral avascular retina, so around 55-60 weeks corrected, I do a fluorescein angiography and EOA, and in that situation, if there is any leakage or they're not reached in zone 3, I do a laser treatment. So we cannot repeat repeated.
In the last year, I saw 3 10-year-old, 9-year-old, and a 12-year-old developing detachment and typical avascular retina, history of prematurity, typical avascular retina in the other eye, and this one was ROP. So obviously, so one has to just complete it.
That's right. I've seen like in UK, 19-year-old girl, the ROP are coming with bilateral retinal detachment. Yeah.
One more comment, please. Last one, please. Sorry, I'm taking your time. The injections, sometimes those people are doing injections who are not well trained in babies. One important caution, you can do it yourself, or you can ask your assistant to press the plunger while you keep your syringe heavy, but it should be very slow. I have seen babies injected elsewhere coming to me, and I could tell that flow of injection has caused a retinal tear. And then you have to do laser. You don't even want to do laser, but you have to do laser because there's a... So even that injection can do that, just the flow of that injection. So it has to be very, very slow.
Yeah. One more comment, like in adults after IVT injection, you can ask like counting finger or see this. So, but in babies, I always check the retinal circulation. So if there is anything like, then can you do ocular massage, something at that time. So always check that even though the volume is very low, that this pulsating vessel or retinal flow is there, it's not occluded. Thank you.
Thank you very much. Our topic is association between hemoglobin levels and severe ROP in premature infants.
Assalamu alaikum. I'm Dr. Nida Khalid, working as a vitreoretinal fellow in the Mayo Hospital, Lahore. I'm going to present my study on impact of hemoglobin levels on severity of retinopathy of prematurity. Objective of my study is to study the correlation between the anemia and ROP needing treatment. It was a retrospective observational cross-sectional study done in 1 year from July 2024 till June 2025. It was done in ROP screening room of Mayo Hospital, Lahore. The babies with birth weight of less than 2,000 grams, gestational age of less than 35 weeks was included according to PROPERA classification. Their valid CBC reports were included along with recorded fundus examination. Recording screening performers included birth weight, HB at the time of presentation, staging and zones of ROP. ROP staging was done according to ICROP, in which stage 1 ROP or less was classified as mild or no ROP, whereas stage 2 with plus and stage 3 or more was classified in VN threatening ROP. HB was classified according to HB less than 10 or less or equal to 10 as moderate or severe anemia group, whereas more than 10 was mild or no anemic group. The results were concluded that low HB level, she was showing 80% of aggressive ROP, whereas optimal HB was showing 20% of aggressive ROP. But as well as the zone 1 was affected more in low HB group as compared to the optimal HB group. Similarly, the treatment requirement was more in the low HB group, that was less than 15. Then when we classified the babies according to HB and birth weight, they concluded that low HB with low birth weight was causing 70% of VN threatening ROP. Whereas good birth weight was showing a better figure, but low HB was including it to 35.2%. Similarly, gestational age is a risk factor, but adding low HB increase the percentage to VN threatening ROP. So anemia was actually a rectifying factor. This was done to because the treatable ROP rate is 20.6% in Pakistan as compared to high income countries. That is 1.8%, very low. And it is because of inadequate ROP programs in our country, high rates of ROP related blindness, and high rate of nutritional deficiencies that is exhibited by maternal malnutrition. The Lee et al. Also studied this gestational age and effect of zone 1. That is also concluding relative to our study, that is also showing that zone 1 is affected more in anemic infants. And our study was showing a U-shaped relationship to the treatment. Our study is first to report 3.5 times higher risk of zone 1, and our study is first to study aggressive ROP, that is 80% in anemic infants. As it was a retrospective study, so transfusion level and EPO levels that are more important, this is a limitation of our study. So we concluded that anemia exhibit ROP severity. There is high relation of zone 1 with anemic infants, and low HB patients or infants were requiring more rate of VN threatening ROP. Thank you. Any questions?
Fine, and the other one was developing. So that is when we started doing the HB levels at Hamid Zatif Hospital, and since then, it's amazing. I mean, it's surprising that so many babies come out to be 6.5, 6.7 kind of hemoglobin, and so I always request them, that if it's under 9, do transfusion. If it's between 9 and 10, then increase the iron supplements and all that, and that's how they work. But their explanation was that it happens to, there's that immature hemoglobin, and then that finishes and that changes into the mature hemoglobin after birth, and that is around 6 to 7 weeks.
Even transfusion is also increasing the rate of severity.
बिल्कुल, लेकिन ये बात था, उन्होंने इसके रीज़न बताया था कि वो HP नीचे जाता है बिकॉज वो इमेच्योर फीटल हीमोग्लोबिन जो है वो चेंज हो रहा होता है आपके मेच्योर हीमोग्लोबिन में. सो कहीं ना कहीं कुछ एक्सपेक्ट करना ही पड़ता है, लेकिन बहुत लो लेवल्स पे आपको देनी पड़ती हैं. लेकिन और ट्रांसफ्यूजन वगैरह हमने तो ये देखा है कि उसके देने के बाद एकदम से ROP बढ़ती है, लेकिन नॉर्मल भी ग्रो करती है.
Nice presentation, Dr. Tanveer. Acha, yeah, that's very true that when you transfuse adult hemoglobin into a child, there's affinity for the oxygen is much less, so there will be like free radicals available. Another risk factor which was proposed in 2022, I think, is proteinuria. So children who are born with and they have proteinuria will have higher chances of ROP later on, and this is what at the moment I'm conducting in my hospital, and I advise them that जितने patient में they complete सबका जितने patient premature हैं उनका ये कराया करो, proteinuria जरूर कराओ, because if we recall from diabetic retinopathy, we feel that a similar sort of capillary system is present in our kidneys and also in the eyes, and when the eyes are affected, the more likely the kidney will be affected as well. So proteinuria is another risk factor. You can do your research on it. Thank you.
Thank you very much. Next, I'd like to invite Dr. Khushbakht Peters for our presentation.
So this is actually directed towards people who are starting ROP screening and people like me, who are just who have started doing ROP screening on a regular basis. So I actually run an ROP clinic at a pediatrics hospital. I went in a different direction. So the purpose of this is this presentation is to highlight the occurrence and the clinical course of unilateral ROP, and the emphasis of vigilant follow-up in these kind of cases where there is initial symmetrical retinal vascular development. I'll be discussing 3 cases. So we had one case which presented a few months ago. Since we don't have a red cam, so we'll just going to have to use these images. So this case presented, and in one eye, the patient had immature vascularization that progressed on to complete vascularization. One eye had immature vascularization that progressed on to complete vascularization, whereas the other eye, it developed into stage 2 ROP. A second case presented, and both eyes again had immature vascularization, One eye progressed on to stage 1, the other eye was completely fine. The third case was a pretty interesting one. One eye presented with complete vascularization later on the follow-up visits, and the other eye, stage 3 ROP. And this actually happened after the child had received oxygen for 48 hours. But I was surprised that the other eye was not affected, only one eye was affected. 1.4% infants all over the world, they say, they develop unilateral ROP, but at the same time, the studies showed that different populations, it depends upon the population that you are dealing with. So different populations have different percentages. Roughly 7% of the ROP population have unilateral ROP. It is clinically impossible to predict whether immature vascularization will progress on to normal vascularization or ROP, and that is why follow-up visits are very, very important. Now, why does this happen? It happens because there is uneven blood vessel development. And I was surprised because I never actually thought of that. And why that happens? Genetics. Certain babies have these kind of genetics in which one eye will be completely normal, the other eye will have ROP. For Pakistan, the percentages for unilateral ROP, they weren't available. So maybe that's a study you can do. The follow-up visits, well, these are the follow-up visits according to the American Academy. But when one eye has complete vascularization and the other eye has ROP, even if it is stage 1 ROP, you need to check the patient regularly. You cannot take that for granted, as most of us do. So in conclusion, ROP typically is a bilateral disease, but unilateral presentations can occur and can be under-recognized. It is very important to remember that. So vigilant screening and follow-up is very, very important. Thank you very much. Any questions? No. Okay. Thank you.
I am Dr. Mehreen Akram. I'm a fellow of pediatric ophthalmology and strabismus at Mayo Hospital, Lahore. Today, I'll be sharing with you our work on how does timely compliance towards first ROP screening directly relate to final retinal outcomes. So why does this study matter? Let's go through a little bit of background. We all know that Pakistan is going through something we know as third epidemic of retinopathy of prematurity. And more premature babies are surviving, which is wonderful, but this also means that there is a big burden of ROP these days. And thus the OSP screening criteria has been expanded to include all of these bigger and heavier babies. Still, early screening and consistent follow-up remain key challenges in our setting. And the major cause of blindness is late presentation mainly. So the screening criteria for developed countries like the UK is gestational age of up till 31 weeks and birth weight of up till 1501 grams. But for our country and other developing countries, it's 35 weeks and 2000 grams. The objectives of the study were twofold. The first one was to see how well our real-world screening practices align with the guidelines, and also to assess the impact of timely versus late presentation on eventual retinal outcomes. Let's go through how this study was conducted. This study was conducted at Mayo Hospital, Lahore at our ROP clinic between Jan 2023 to December 2024, a 2-year study. And it was a retrospective chart review. Around 366 infants were referred to us, but only 270 met the criteria, so those were included in the study. Further, the newborns were divided into 2 groups, compliant ones and non-compliant ones. The compliant ones were the ones that presented within 4 weeks of birth, and the ones that presented afterwards were non-compliant. And the main outcomes were 5. They could either have normal vascularization, those that did not develop any form of ROP or did not require any treatment were in the normal vascularization group. Then any ROP that did develop some form of ROP, but they did not require any treatment. Then type 1 ROP, those that did require some treatment, either required anti-VEGF injections or laser or both. Then the loss to follow-up, a major challenge for us. And finally, retinal detachment with stage 4A or worse. Moving on to results. Out of 270 infants, around 124 were non-compliant and 146 were compliant. And this is a chart that will give you an overview of baseline characteristics. Here you can see that the most significant finding is the difference between the age at first visit. And this was also statistically significant. Interestingly, the proportion of infants developing any ROP was higher in the compliant group. And you can see that normal vascularization and type 1 ROP, they were similar across both of the groups, while 48 infants were lost to follow-up. None of the infants from compliant group had retinal detachment, while 8.1% of the non-compliant infants developed retinal detachment, and this was highly significant. Out of these patients with retinal detachment, 8 out of 10 presented with an inoperable stage 5 to us. And we all know that this all could be prevented. It's all preventable if they presented timely. This is a summary table for the findings. You can see the retinal detachment, none in the compliant group, all in the non-compliant group. We also gave a questionnaire to the parents to find out what are the main causes for this late presentation, and we found a consistent pattern. The most common cause was inadequate counseling by the NICU team. This is because there's not enough communication between the NICU and the ophthalmologist. And then poor awareness and lack of knowing how aggressive disease is and how bad it is for the babies. Then geographical and transport barriers, personal reasons. So a baby presenting so early and still blind. To summarize, delayed first screening is strongly associated with poor final retinal outcomes. The difference between an attached retina and a stage 5 retina is just the time of presentation. So 4 to 6 weeks postnatal is the critical window period in which the baby must present. Globally, late presenters should be referred to tertiary care hospitals promptly because they need urgent treatment. Thank you. Thanks all.
First of all, जो आपने कहा था कि third epidemic पाकिस्तान उसके through गुजरा, it's actually all over the world. The entire world is going through that, and it's an epidemic of the world. The second thing is कि आपने जो point out किया था कि neonatal ICUs और ophthalmologist के दरमियान वो जो contact होता है वो बहुत ज़्यादा कम होता है. उसके लिए आप लोग कुछ कर रहे हैं?
Yes, we are constantly conducting meetings. अभी हमारी वर्कशॉप्स हुई हैं 2-3 जिसमें हमने उनको बुलाया, अवेयरनेस क्रिएट की है और हमने एक रेफरल सिस्टम भी अच्छा बनाया है. हमारी एक रिप्रेजेंटेटिव है जो वहाँ जाके स्क्रीन करती हैं सारे बेबीज़ को और फिर उनको रेफर करती हैं. वो अलग काउंसलिंग करते हैं और न्यूटोलॉजिस्ट अलग काउंसलिंग करते हैं. So at Mayo we are working really hard towards this reason.
And does the person, does he or she call them for follow-ups?
Definitely, yeah.
So
she has all the numbers.
Okay.
If we have to go to the NICU to examine the patient, we do go.
Okay, okay.
We even give intravitreals over there after sterilizing everything. We've done that recently, yeah.
Interesting, interesting. Thank you.
Thank you. Very nice talk. Thank you. Yeah, compliance is the problem, and right now, what with those children I'm seeing coming through my clinic into my clinic with grade stage 5 or plus disease, they have not been made aware properly. They have not been given the proper awareness. मैं उनसे पूछता हूँ, why did you come late? And he said, हमें कहाँ गया था, बस एक दफ़ा check करा लेना. So this is so important that my sentence in every presentation is no child should go blind through ROP. And if it does, कहीं ना कहीं gaps हैं, आपको fear डालना होगा. You have to put fear in parents' mind. Here, the patient is not the child, it's the parents.
Exactly.
You have to make sure that they have this fair understanding that agar hum ek din bhi late ho gaye, so because there is a window, very small window, the child can lose, तो उनको बताना होगा कि ये अंधा हो जाएगा. उसके बावजूद भी one of my patient actually they went to Peer Fakir and they actually changed the name of the patient and said कि नहीं नाम बदल लो, ठीक ये डॉक्टर तो ऐसे पैसे कमाने के लिए करते हैं. And that child is blind forever. उनकी जब दोबारा एक बेटी जो है वो premature हुई and they brought straight without any notification मेरे क्लिनिक में आके बैठ गए, डॉक्टर साहब इसको देखें, इसको शायद इंजेक्शन की ज़रूरत है. And I said at the expense of one entire baby, you've learned this lesson and that shouldn't happen.
Exactly, sir. It's heartbreaking.
वो पहले वाली प्रेजेंटेशंस में हुआ था, वो जो मीडिया यूज हो रहा था कि जी सब वीडियोस एंड लेक्चर्स एंड व्हाटएवर, दीज आर ऑल गुड डिपार्टमेंटल लेवल और व्हाटएवर. पैम्फलेट्स, यू नो, पैम्फलेट्स आर वेरी इंपॉर्टेंट, चाहे वो ब्लैक एंड वाइट हों, सस्ते हों, जैसे भी हों, मैं हॉस्पिटल में दे रहे, लेकिन वो निक्यू में मौजूद होने चाहिए.
Yes, sir. Yeah.
क्योंकि आप मसला ये है कि जब आप उनको समझा के भेजते हैं तो वही वाली बात कि घर में पीर फकीरों के पास ले जाने मेरे इतने बेबीज होते हैं, वो उनके ग्रैंड पेरेंट्स मना कर देते हैं कि डॉक्टर तो पागल है. छपी हुई चीज़ जब सामने होती है ना, वो थोड़ी सी ऑथेंटिसिटी जो है वो दिखा देती है.
जी.
तो वो साथ साथ दिए जाएं तो वो भी हेल्प करते हैं, वो सारा.
Thank you very much. I would like to request Dr. Tanveer Chaudhary for his presentation. And at the end of the day, I think everybody will agree that we need a counselor, a dedicated counselor for this retinoblastoma, retinopathy of prematurity.
Thank you. Okay, so no disclosures for the talk. ROP is something very close to my heart. I am not a pediatric ophthalmologist. I'm a cornea and refractive surgeon, but when I came back from England and joined Aga Khan, nobody wanted to see children. They're messy, they're loud, they're noisy. Hum nahi tolerate karte. And I said, okay, I'll become a child, one of them, and I'll see them. From since that, like 20 years now, and I've been doing, and I've published few papers on ROP as well. जो आप कह रही थी, changing the criteria, किसी ने कहा था 34-weeker. 2015 March 2015 British Journal of Ophthalmology, my paper is published, although there was no result, but it was so interesting that they accepted it for me. Anyway, as I said, I start with and I finish with that no child should go blind with ROP, through ROP, and kahin na kahin hamare problem hai. I'm not going to go into the background. Everybody knows how it started, how it's diagnosed. Sirf ye tha ki when it was first diagnosed, pata chala ki ROP bhi koi cheez hai. People actually thought ki it's oxygen, and they stopped giving oxygen. So many children died, but ROP still existed, and I said no, it's not that. Then came prematurity, always low birth weight frequently, and oxygen variable, along with other risk factors which are still evolving. So we have been passing through epidemics. We have been passing through epidemics of not knowing, knowing and not equipped, equipped and no awareness. And I think at the moment in some developing countries, in many developing countries, the problem is with non-awareness and non-compliance. We should never see this happening. We should never see, we can see this, we have to treat this, we should not see this happening. But unfortunately, it's heartbreaking when the child comes and remote areas से अभी भी मेरे पास आते हैं, even कराची से मेरे पास अभी भी आते हैं बच्चे इस पोजीशन में कि जी हमें बताया गया था, हम नहीं आए, हमें बताया नहीं गया था, and so on. It's very easy to blame others at that time. तो वो कहते हैं कि हम क्या करें, अब क्या कर सकते हैं, हम कुछ नहीं कर सकते. तो ये स्टेज से ये स्टेज नहीं आनी चाहिए. क्यों? बिकॉज द ट्रीटमेंट इज वेरी सिंपल. ट्रीटमेंट इज एंटी-VEGF, ट्रीटमेंट इज विद लेजर. एंड रिसेंटली मैं अभी डॉक्टर खालिद को बता रहा था कि 2 days ago आई वेंट टू सी दिस चाइल्ड एंड चाइल्ड नीडेड एंटी-VEGF एंड द डॉक्टर सेड ये तो वहाँ नहीं जा सकता थिएटर में. मैंने कहा आई विल ब्रिंग थिएटर हियर. It's that important that I'll bring theatre here, and मैंने उनको injection लगाया. Maybe they need laser. I used to do a lot of lasers, लेकिन laser के किए हुए अब मेरे पास बच्चे आते हैं, and many of them are myopes, and you know that laser has got this complication.